Okay, so good evening. My name is Neil Warshawsky, and I'm going to try and over the next hour kind of run through a bunch of stuff about microosteoperforations and stuff like that, and kind of show everybody how we use this in our practice and how it's affected my world, if you will. And hopefully everyone's going to be able to see what we're doing and kind of get an appreciation of how much this has affected us. So again, my name is Neil. I'm in Chicago. I'm a graduate of the University of Illinois, where I currently have an assistant professor job at the Craniofacial Center, where we do a lot of crazy stuff and we help a lot of kids. And in addition to that, we really just treat a plethora of issues of growth-related issues. So tonight we're going to talk about something that we added to our practice about 5 years ago, which is acceleration. I'm going to show you kind of how we use it, and you'll appreciate the fact that I'm a little bit of a tech junkie and that things go pretty well. So right now, a couple of disclosures just to let you know I'm not employed by Propel or any other company for this webinar. This is myself speaking to you. I don't own any stock in any of these companies. I don't have any family members in these companies. I am a consultant to them, as well as for 3M Oral Healthcare and Dentsply Sirona. And I make a living doing orthodontics in my private practice and at the University of Illinois. I've been compensated for this conversation with you, and as a result of that, I do receive monetary money, but short of that, you know, my opinions are just my opinions. The materials here are my own. This presentation is for an hour of CE. You are not allowed to or permitted to use any of these photographs other than for learning for your own entertainment. You can't show these to other people because these are my patients, et cetera, et cetera, et cetera. Most importantly, sorry about that. We are going to be on time tonight because if you know anything about my practice at all, my practice is on Waveland. I am 6 blocks west of Wrigley Field. Game time is 8:04, and we have an hour to get this done because I'm going to the game tonight. Woohoo! Go Cubbies, let's get some runs. All right, so the science behind microosteoperforations. So what happens when you do a perf in the bone is you create an injury, and it creates an inflammatory response where cytokinins get ramped up to remodel the bone. So what you see normally in tooth movement is when you're pushing on a tooth and the force is pushing the tooth to the right, one side of the tooth gets crushed and one side of the tooth gets pulled, or as we refer to it as the pressure side and the tension side. So as that tooth moves in that direction, you get remodeling in the tissue. So in order for the tooth to resorb, you'll get macrophages and all kinds of osteoclast activity on the pressure side. You get what's called frontal resorption, causes a little bit of tooth movement because as that pressure leans on the tooth, the bone disappears. And eventually, as those osteoclasts and the other cellular activity eat the bone, they create an opening literally for the tooth to fall into. And that tooth doesn't fall quite so controlled as the image here just showed you. It kind of tips into the area. As it tips into the area, the Sharpie's fibers, which are the fibers that connect from the tooth to the bone, pull on the bone, which causes an osteoblast spike. And what happens is you start to get bone apposition on the tension side of the tooth movement. So as you see, when a tooth is tipped, sometimes heavy forces will undermine the concept. The tooth will move for the wrong reason. So as opposed to bodily moving in a parallel fashion, you'll see the tooth tip. So our goal is to try to make sure that we move our teeth in a controlled fashion. And if we do that properly, what we'll see is that the tooth is going to move in a straightforward manner. Now, this is an example of when you got too much pressure on the tooth and the tooth is actually tipping as opposed to moving in a parallel fashion. So this whole bony concept, what's going on is you have a series of cells all reacting here. You got blood vessels, you got pre-osteoclast, then you got osteoclast, you got macrophages, osteoblast, pre-osteoblast. And it's this dynamic system where it's a combination of pressure and tension causing bone to resorb and to be laid down all simultaneously. So resorption leads to reversion, reversion leads to formation, formation leads to physical bony growth there. Sorry, I got a pretty small screen here and I'm just trying to move my control bars around. And that mineralization probably takes anywhere from, I don't know, 3 to 7 or 8 months to see. When you can see it though, it's obvious. So the original studies were done at NYU, and you can see it was pretty creative what they did. They were all extraction cases, and they were using TADs for anchorage, and they literally were, one side of the mouth had MOPS, which is micro-osteoperforations, and one side had nothing. It was straight extractions, and this was pretty parallel force vectors to retract the teeth. And what they found was that during this experiment, if you will, that they saw almost twice as much movement on the MOP side as they saw as the non-injured side. So what that led them to believe was that, okay, you know, maybe there's something to this. Now, there's different ways you can actually speed up tooth movement, and this is probably the thing that's affected my practice the most over the last probably 10 years, because I think I got into this in 2007. So there's what they call soft pulse technology. The first company that came out with this was Aceleração, and they have a class 2 medical device. They run from $500 to $1,000, and basically this thing vibrates a little bit, causes the teeth to get confused, if you will, and loosens them up. And this device then has 2 claims. One is that it removes up to 40% of the time of treatment, and also their other claim is that it definitely reduces pain. So this specific device is on the market now almost 6 or 7 years. This is probably the 3rd generation of it you're looking at, and it requires 20 minutes of time once a day in a continuous manner to be utilized. And we've had pretty good success using this device. Propel Orthodontics came out with a similar device, which is cheaper, which uses a higher frequency, and this device, as opposed to 20 minutes a day, is only 5 minutes a day. This is not considered a class 2 medical device. And it was registered for seating aligners. So really this device has a very specific purpose, and that purpose is to help seat like Invisalign aligners or red, white, and blue aligners, or any other type of clear aligner, clear correct, or whatever you use in your practice. And this works probably in 5 minutes. If you recharge it, you can do it more than once a day, but anecdotally, I don't think anyone's come out with a white paper showing that more than once a day is effective. So so the advantage potentially over the Aceleração is it's a little bit quicker, but it's certainly not registered as a class 2 medical device. So just understand that. Now, physically, if you want to get into invasive, so both of those were considered non-invasive. If you want to get into invasive ways to accelerate a case, you have several different options. You know, the first one is corticotomies, and corticotomies can be done either in a full flap surgery, or they can be done using a piezo straight through the gingiva. So it's a little less invasive than a corticotomy if you use a piezo. I personally don't do piezo surgery. I have a fair number of patients that have, you know, full-blown Wilcodontics, if you will, which is, you know, corticotomies plus full flap surgery plus freeze-dried demineralized bone grafts, and I have that personally in my practice simply because of the fact that I have a lot of periodontists who refer to me. So both of those first 2 options on the left and the center are relatively aggressive, and then the option on the right, the MOP, micro-osteoperforation, is the least invasive of the three, and it's got a lot of really interesting traction in my practice, mostly because patients don't have to leave my practice, and they don't have to be down for a week, and they don't have to miss work, and it doesn't freak them out, and it's minimal stuff to do. So I've become a big fan of MOPS, and the thing that you'll have to determine in your practice is what makes the most sense with your patient demographic. So manual osteoperforations, or MOPS for short, is a really simple concept. You know, this device specifically comes in 3 different manners. There's the original one on the left, which has a red light that would turn on through those clear plastic windows right here towards the end. And these red lights would go on when you would hit the depth that you wanted to drill your screw into. So over here is a depth gauge. It's got 1357 on it, and the lights here would turn on when the screw would bind that tight into the bone. Now, that was great. It was not very green, and it was very prohibitive on the environment in terms of there was no recycling or anything. So they came up with a second device, which is a sterilizable handle, and then these tips plug into the handle. And this reusable handle then reduced the size of the packaging. The screws were basically the same. The cleared guide around the screw was effectively the same. And what changed here was really just less waste. You know, and then there's a power driver, which is very similar to an endo handpiece, where it's low revolutions here, high torque, low revolutions, and all you're really doing is inserting in the latch grip of it the actual special tip that they make for doing these multiple MOPS. And the thing that you need to understand, as opposed to like using a TAD or a bone screw or something like that, is these screws are designed to be utilized multiple times to perforate the bone, whereas a TAD is a one-time use device. So if you try to cheap out and take a screw and a driver and try to irritate the bone, if you break that screw in the bone, you could be liable, because that device is only meant to be used one time. So the benefits of using MOPS on cases is it's minimally invasive. The technique can be done chairside. We can use it with both aligner cases as well as braces cases. There's really no patient recovery. Really, I design where the MOPS are going. So when I talk to my patients, I talk about it, and I discuss it in a term, I call it mapped trauma. And mapped trauma means I'm going to injure areas of the bone where moves are tougher, and I want the teeth to move easier. But the ultimate thing for me is it saves me time on my cases, which means I ultimately make money if my case finishes faster. Now, the practice benefit is it's pretty technically savvy, and we create some results which are pretty hard to argue with. So I think it reduces my treatment times. I think it's very attractive to be able to sell speed on a case. We incorporated in our premium plans at the practice where I work, which I own, and we sell speed as an option in our practice. And if you pay a several $100 surcharge, we will just accelerate your case, whether it's MOPS or pulsatile, soft pulse technology, or whatever. We'll most likely give you both. Okay, and you know, for me, I don't really care what you use. I just think it needs to make sense for you in terms of what your goals are. Personally, for me, you know, I'm using stuff that really makes a lot of sense. So so we've got a fairly decent amount of traction on some of these cases, so I'll be able to show you how they worked out. So how it works is really you look at a Panorex and you identify the area where you need to move the teeth. Then you locate where the roots are. Then in our case, we'll put a topical anesthetic on after we rinse them with a little chlorhexidine. So we apply the chlorhexidine in a syringe from Ultradent. You can buy it directly from them. The product it has a name on it, which I'm not trying to sell any products for them, but I do like the fact that Ultradent sells very small syringes, disposable syringes that you can load the chlorhexidine in, and the tips to swab the areas come in many different formats, so you can get a sponge or a brush, whatever works for you. So most of the times I'll tell you that when I use mops, I apply it 2 times. If a case is really tough, I'll do a 3rd time. I've yet to do a case more than 3 times. I explain to the patient that wherever the tip of the screw goes into the bone and creates the perforation, you get a radius of about 3 to 4 millimeters. On a great result, sometimes even 5. So if you're looking at the diameter of the area that's been affected, that area is anywhere between 6 and 10 millimeters where the bone is going to get injured, and as a result, when it goes to repair itself, it will soften. So typically, I go in anywhere from 1 to 3 millimeters, with the exception of the lower posterior sections. And if I'm by the molars in the lower posterior, sometimes I'll go all the way 7 millimeters in, because the bone there is so incredibly dense, it's hard to get a good trauma response, you know, if you're just at the surface. So within 24 hours of doing the mops, the activity will start. Usually I think it'll last 8 to 12 weeks. We ask our patients during that 8 to 12 week period that they will not use any non-steroidal anti-inflammatories. And then if they are uncomfortable, they can use Tylenol. If they have a problem beyond that and they call me, then that's okay. I can always give them something a little stronger to get them through the night. So as you see here, the mops can be either both buccal or lingual. The picture on the bottom here shows you what the patient looks like directly after we mopped them. The picture on the top shows you the palate being injured. So if you follow me here, then if you see the map of the teeth and you can see where all these teeth are, these numbers represent how many different perforations I would do along the root. So typically on the anteriors, on the lower, I'm lucky I'll get 2 or sometimes 3 perforations. You got to be careful as you get closer to the mucosa. The mucosa will start to wrap around the screw tip, and if you turn too fast, they'll start to wrap on the screw itself, and you'll do more trauma by screwing it in than anything else. Typically what I'll do is I'll do a diamond pattern between like my lateral and my canine, or my canine and my first bi, and then as I'm going farther back I start doing parallel lines again. But in areas where I know the roots are going to diverge, I tend to do like a pyramid of perforations. And to be honest, what I've learned over time is the more aggressive I am with the perforations, the better my response becomes with my patient. So I tend to be relatively aggressive, I guess, from your standpoint, if you've never done this. And I'm not going to be so concerned about whether my patient's comfortable or not, because I'm going to make sure my patient's numb. So if I have a patient who's very apprehensive, I'm going to leave my topical on for 5 minutes. I'm going to rinse it off. I'm going to reapply my topical. And this is really, really strong topical anesthetic that I get compounded for my practice. And it's tetracaine, lidocaine, and prilocaine. So it's got a little bit of vasoconstriction in it. It's got definitely a fair amount of numbing to it. And then once that's sat for 10 minutes, I've completely rinsed it off and cleaned the area up. At that point, I'll oftentimes give them a local if I feel that they're going to be scared. And then I push hard on their shoulders, and I explain to people that you can't knock out the sensation of pushing. You can only knock out the sensation of pain. I think most people understand that when I do that. So literally, this is what, this was my very first mopping case. This is the first time that I injured a site, if you will. And you can see that this is an extraction site, and I am just drilling all over that extraction site. And you notice I went on either side of the frenum, because going through all that mucosa is just going to be traumatic to the patient. But I also went between the bicuspid and the first molar, and I went all the way up to the lateral incisor, because we were retracting the teeth on that case. So the technique with the removable handle is really pretty simple. Insert the tip, hold the driver 90 degrees to the surface you want to injure, rotate clockwise. You'll feel it when the screw tip feels like it's grabbing the bone. Then you got to watch the clear indicator on the edge here, and that'll indicate how deep you are. And then you just got to determine whether you want to be like 1, 3, 5, 7 millimeters deep. And then when you're good, just reverse it. The power technique's a little different because in my estimation, sometimes when you're learning to use this thing like I did, I actually had an assistant hitting the reverse button for me. So I would, with my left, I'm a righty, so with my left hand I'm pulling the lip down, and the right hand I'm mopping the sites using the tip. You know, so we'll numb them up. We'll put the chlorhexidine on. We drill them, and then when we're done drilling them, we'll wipe them down with chlorhexidine. I put a cotton roll in there and I let them sit for 5 minutes or so, and usually by the time I pull the cotton roll out, there's no more bleeding. So generally speaking, I put the thing on high torque, I put my RPMs on 30, and I'm good to go. So it's not very hard. Turn the driver on, you turn it off when you're finished. So typically I'll turn it on, I'll drive, I'll see how deep I go. I stop it, I hit reverse, I start it, I pull it back out, I stop it again, I hit reverse, now it's back and forward motion, pick my next site, and away you go. So our patients leave with 2 Tylenol and an envelope. They also leave with a postcard that says they're not allowed to take NSAIDs for the next 10 to 12 weeks. We also give them a phone call a week later to find out how they're doing. And almost invariably what people tell us is after the second day they had no discomfort at all. So, which is shocking to us initially because we didn't understand what to expect. So you'll find that your CE is going to come tonight from Catapult. If you have any questions, you can go straight to Catapult if you don't get your certificate. So the rest of this is all going to be clinical cases, compliments of me. You're going to see a series of about 9 or 10 cases where we're kind of go from easy to hard. But I would call none of these cases necessarily easy. So our first one I'm going to show you is kind of a narrow case. You can see this guy feels like his 2 front teeth stick out pretty far, and his desire was to broaden his smile. So I would definitely call this a surgically assisted rapid palatal expander 10 years ago. I mean, we just didn't know how to do anything but that 10 years ago. And I did a lot of them. I probably did over 20 a year. And, you know, we got pretty good at it. But the problem was that with surgical rapid expansion, when you go really fast, you get this massive diastema, and then you almost strip the tissue off the mesials of teeth number 8 and 9, and you have a hard time recovering your papilla. So our goal is always to try to make sure that everything goes well. So in this case, what I did was I mopped the guy on the buccal segments from the lateral back to the first molar, and I put in what's called a nitipalatal expander, or an NPE, and I let this go for almost 4 months. At the end of 4 months, I put lingual braces on him because it's one of the niches in the world that I'm pretty good at. I know how to do inside braces. And you can really appreciate that the image on the right showed what I predicted my case to look like, you know, in terms of the design. The middle picture was only my 8-month result, and the picture on the left is how I started my case. So this is what he looked like at 8 months. So you can see just in the photos that he was showing more teeth. His smile was much brighter. I know he needs to do some dental work on tooth number 8, but you can appreciate the fact at least we had an impactful change in a little less than 3/4 of a year. So about 2 years, or it was about 20 months or so, we wrapped our case up. It may not be perfect in terms of the midline. This guy was just thrilled to death, and given his line of work, he was a newly hired police officer. That's why he had the lingual braces. He didn't want anyone to see the orthodontics on him, and it worked out pretty well, and he was pretty pleased with everything. So, and you can see this is what this guy looked like. This is a coronal cut through the CAT scans at the level of his second bicuspid, and you can see his teeth are oriented straight up in the bone. Here he is And if you measure that distance, it's 22 millimeters across. This was his pre-treatment number. So when I was finished with him, I think it's pretty obvious. You can see at the level of the buccal, there is plenty of bone on the outside here. And I don't know too many people who've really taken the time to study CAT scans post-operatively on their cases, but this is a good example where not only did the guy maintain all the bone around his teeth, and you'll see it'll get better over time, but in addition to that, this guy expanded 8 millimeters. Now that's a really impressive number to be able to say that not only did you widen the case 8 millimeters, but there's no damage on the teeth at the end of the day. And here's the coronal view showing you right through his second bicuspid. Again, this was the shot I just showed you. And this is what he looks like, an oblique view from the cone beam, showing that, in fact, this is all bone here around all the roots. And this is the tooth in question. And you'll see over time that this will re-solidify, and he'll actually have more bone in a year than he has now. So this is really impressive, because I've never been able to expand a case 8 millimeters when they are 30 some odd years old. And yet here it is. So a year into the case of retention, okay, I decided to take photographs on him. So this was him at the start on the left. This is him when we finished at 20 months of treatment. And this is him almost 13 months after we finished the case. He finally got a crown on that front tooth. I was able to get him to come back. And you have to say, if you look at the picture on the right and you look at the picture on the left, you have to say to yourself, my God, I mean, this really worked. I mean, this was a tremendous change for this guy. He felt better. Periodontally, he's much healthier. All things being what they are, I think this guy did really great. So in this case, we finished almost 6 months ahead of schedule, and we did pretty good. So here's a class 1 with a bilateral palatal crossbite, that really severe anterior open bite. This is a second case now, minimal overjet. And she walks in the door, and we're the third or the fourth orthodontic practice to look at her. And at this point, she's heard surgery, surgery, surgery. So when we looked at this X-ray, to me, this really wasn't a surgical case. To me, this was probably going to be something to the tune of a lot of rubber bands and some orthodontics. So what we did was we decided to try the case non-extraction, non-surgical, just using micro-osteo perforations. We're gonna across the entire maxillary buccal cortex. We're gonna do mops. We're gonna do vertical elastics. As I told you at the beginning, I'm orthodontist number 3 to talk to her. She chose me, and this is how we did. So month 2, this is the day we did the mops. You can see the bleeding. It's not terrible. It's a little oozy, but nothing too crazy. And that's one of the things that you got to really experience to believe, that when you do this, there's just not a lot of bleeding. So in 14 weeks, look at the difference. 3.5 months, look at the difference in the vertical closing of the case. So at this point, I knew I had the right choice. And at this point, I kept the case running. So now she's wearing rubber bands. That 8 to 10 week window is ending. So I'm getting ready. So now we did it a second time. Probably could have done a little bit better job rinsing her off. You can see the funny thing. She may be bleeding here. She's actually smiling. So you can tell, honestly, the mops didn't bother her very much. At 5.5 months, we had her bite almost fully closed. And at that point, I thought we were going to be done in 9 or 10 months. So if we would have finished in 10 months, we would have been done 60% ahead of schedule. As it turned out, we were done in 47 weeks, which was not quite a year, but we had a 55% reduction in time. We had a beautiful result, and we had a very happy patient. So when you look at something like that, the case fee was the same. We got paid for the cost of the item to do the mops, but at the end of the day, if you look at what we earned per month, we earned over $600 a month versus $250 a month. So you can charge whatever you want, but at the end of the day, I think that doing the mops here allowed me the ability to make more money. Now here's an African American who you probably don't think is going to need orthodontics. This is a multidisciplinary case. He had a trauma, had some teeth knocked out, and he decided to get braces before he got restored. So we're going to put him into a class 1 occlusion. We decided to use TADs to anchor the case down. We had some extreme bone loss at 23, so we're going to pull tooth number 22 into that region, get a little bone transport going, and hopefully avoid a bad implant site. So this is, his name is Lonnie, and you can see that Lonnie was kind of banged up a little bit. He's got some calculus on his teeth. He's missing a bunch of teeth, and you wouldn't think that Lonnie would be the person that we'd be treating, but he is our patient here, and you can see his teeth are pretty flared. So my dentist, who's going to restore the case, was very specific as to what she asked for. She's like, I need the edentulous sites made smaller, and this guy, even though he's in his 60s, is built like a truck because he's a Coca-Cola driver, and he hauls cases of Coke all day long. So we put him into hardware, and we anchored him with some TADs, and we started to see what we can do with him. So here he is a year into the case, and you can see that things are getting smaller. And then we kept going with the mechanics. Here he is at 1.5 years, and we're starting to get the midline on. Here he is at 2.5 years, and I thought at this point that I was going to be pretty good. I'm like, okay, you know, I've got enough vertical room for the implants, and you know, the sites are reasonably sized. And then I get this Panorex from my restorative person, and they're like, what are you doing? You're killing me. This is a non-restorable site. I can't place an implant because the root of the canine never moved when we did the bone transport, because apparently the site was just not very receptive to the movement. So what happened at that point, guess what? I mopped him. I know how to fix him. That's me on the spot doing it. So this is him at the start of treatment. This was him at his 2.5 year mark. 4 months later, you can see that the site looks almost the same, except when you look at the Panorex, taken from my cone beam X-ray, you can really appreciate how parallel that site is for the implants. So we did a very good job in a short period of time that otherwise I failed at for 2.5 years. So that's some damning evidence, I think, that when you need a get out of jail card, when you are stuck and you have a tooth that's having a hard time moving, I think mops are an incredibly smart way to make teeth suddenly move. Sorry, I'm just moving my control panel over here. And again, here's my here is my final film, and you can see this is really pretty stellar stuff. You see some really amazing sites here for restorations. Roots are out of the way. There's no question he can be restored now. Here's another person. Now this person is only 25 years old. He had minimal crowding. He's missing his upper lateral incisor from birth, and he wants to do an implant. Now you probably see this case a lot, you know, congenitally missing implant. And I gotta tell you, this is a pretty hard move. So what I had going for me here was he still had his deciduous canine, so I'm gonna extract the deciduous canine, I'm gonna distalize the real canine, I'm gonna create an implant site, and we're gonna go from there. So this is as parallel as it gets. And if you know anything about moving canines backwards, when the teeth are tipped, they're very receptive to move. When the teeth are upright like this, incredibly tough to move. So I think that this is about as hard as it gets to try to distalize. Here's the cone beam. You can appreciate how little bone is over this canine, okay? So that's another concern of mine. Like, you can see this tooth is just sticking out of the buccal plate. So this is my patient on the day that we mopped him, and you can see that he's a little red and irritated because we had just done it. He has got a little bit of blood there, so I apologize for that. But he overall is doing quite well. Now, you can see from day one, I mopped this guy, okay? And you can see in between the teeth, you can see my line here. I've got a line here. I took the baby tooth out at the same time. I went all over this extraction site with, and perforated it and did mops all over the area. I really tried hard to injure the area so that as it started to heal, my teeth would have an easier time moving. So at 6 months, you can see that I had a decent amount of movement. This tooth is relatively parallel to the central, but I don't have enough room to place an implant yet. And by the way, I'm not fully closed. At 7.5 months of time, I was good. So at this point in time, I said to my patient, I said, you know, you're ready. So I sent him to the oral surgery department. Although he's a private patient of mine, he went to the dental school to get his work done. So OS went ahead and did, they felt that the quality of the bone here was not enough for an implant. I don't think that was actually true, but it allowed me to get some amazingly cool pictures. So this is our original canine position. You can see this is a coronal slice through the canine. And you can appreciate the negative crown torque on the left side right here, okay? This canine is in the wrong position. So when the oral surgeons went in to graft the site for the implant, which is right here, I want you to look and see how little bone is over this canine, and yet the canine doesn't need endo. It's not acting up in any way. And I have to tell you that I can't imagine what the tooth would have looked like had I not mopped the area. But this looks like the canine is sitting in the middle of nowhere. So 7 days after his bone graft, you can see he looks pretty reasonable. And I think that this is really a very effective way to get somebody to move with less stress on the teeth. When we took them apart, you can see here's the screw where the bone graft is in place. And when we took him apart, you can see exactly what he looked like. I mean, this is a perfect site for an implant now. And when the case gets restored, I'll get final photos and you'll see it. He should have a crown by Christmas, I think. So you got to wonder what would have happened had we not used, in this case, the Propel. Now here's a severe diastema with a girl who wanted to get married. She's 93 days away from her wedding, and she walked in the door and she's like, "Can you close my gap for my wedding?" I said, "No, I can't." I said, "I can get you pretty close." I said, I'll never get you, 100% there, but I'm likely to at least get you partially closed. So I said to her, there's only 2 conditions I have if I'm going to try and help you before the wedding, and I'm like, because I only have 93 days. I said the most important condition is you're going to start immediately, meaning tomorrow. And the second is you must consent to mopping. And she agreed to both because I let her know that I thought I'd have a pretty reasonable chance of improving her smile. So this is the next day. I put her braces on and we mopped her. By week 8, she looked significantly better. Now you got to really look hard at that bend in the arch wire, right? And realize how much those teeth leveled in such a short period of time. So at week 10, I thought I had a pretty good result. Now, 10 times 7 is 70. I still have 23 days before the wedding. So I decided to re-propel, remop the area. And this is our second session. You can see the bloody spots where I do it. And this is what I looked like on the day that I took her braces off. So she was it was really week 13, and it was 91 days. I finished 2 days early because I didn't want her to go crazy on me. You can see she's got a smile on her face. You can appreciate the change that I made in a little over 3 months. And I would say that anybody who is looking at this has to say, okay, this is real. And we did a bonded wire and a clear aligner for her to hold her in place. But I told her I still wasn't finished. And believe it or not, she came back after the wedding and let me put the braces back on. But she did ask to take a selfie with me, which I thought is lovely. And she's really adorable, and she's really funny, and she just loves her teeth. So the question really is, what's the limits? Like, can you do removable appliances with this? So now I'm going to show you a 41-year-old. This was my first Invisalign case that I accelerated. And I gave this guy everything. I gave him an Acceladance, I gave him mops, and what I did was I had a really short period of time. I had to get him finished because he worked for the UN and he was going to be moving. It wasn't my idea to actually switch out the aligners as fast as he ended up doing, but I'll just say that by the time we were finished with the case, he was wearing his aligners between 3 and 4 days. So he would, the moment he felt that they felt well, he would just switch to the next aligner. So this is the ClinCheck showing, I don't know if the movie will show or not. Sorry, my video link isn't working. But as you can see, this is the position of how he started, legitimately crowded. And my goal was to try to align him the best I can, because this guy was likely going to move on me within 5 months, and I was trying to get the case as close to being done as possible so I can transfer him. So at stage 20, I decided to take records, and he didn't look terrible. This is where he started. This is where he was. And I took the photo and I put it up against the stage 20 on the ClinCheck, and I said, now, how does this appear? Does this appear close to what I predicted? And I think the answer is going to unanimously be, yeah, this is pretty close to what I expected to see, which to me was shocking, because I really didn't think that it was going to work well. You know, and I finished the case in 105 days, and it's not the hardest case, but you know, for being the fact that I had never accelerated an aligner case before, it made me really appreciate the fact that, okay, you know, there's something to be said for this acceleration concept. Now here's the case at the beginning, and the picture on the ClinCheck on the left shows you how he started. The ClinCheck on the right shows you how he was supposed to finish, and then the photo on the bottom shows you actually how he did finish. And I have to tell you, I'm not embarrassed to show you this result. This is a very acceptable result. It may not be perfect, but I gotta tell you, it is absolutely acceptable. And this patient was just 100% thrilled at the change that he was able to get in less than 4 months. So here's a little bit of a tougher aligner case. Class 2 Division 2, right? She's 50% to 75% Class 2, right? And our goal is to improve her lip support, improve her smile aesthetics. So we started out our case attacking the Class 2 with the Carrier system. I don't know if you use this or not, but I think this is a pretty brilliant way to knock out some of the Class 2. So we get a little molar correction before we go into our aligners, which makes the amount of elastics worn in aligners less. Then after 4 months of that, you can see spaces have developed right here, showing you really the buccal segments have moved, the molars have rotated, so we strip off our appliances, our midlines are a little closer, and then we go into our clear aligner system. And at this point, we're like, okay, you know, so then we start delivering clear aligners, and then the clear aligners take her from Division 2 to Division 1. You can see that she's getting a little more lip support up here. She's appreciative of the fact that her lip's a little fuller, and at Cupid's bow here, that the midline isn't quite perfect, but it's pretty close. She is tending towards class 1 here. She is class 1 on this side, and she was pretty thrilled. And we purposely didn't plan to do an exact finish here because that wasn't her goal. She wanted to be done as fast as possible. And after 8 months of aligner therapy, the patient was simply satisfied, and she's like, great, I love my results. You know, can you hold me here? And I said, absolutely, I can hold you there. And we went ahead and we retained the case at this point. So if you look at the predicted result and you look at the actual result, I think what you have to say is, yeah, you know, this is pretty close to what we're predicting we're going to hit. We're right on the money. Now here's a case that transferred to me. This is kind of a little bit of a goofy case. This guy is coming to me. He's full class 3, transferred to me from a doctor I know in Israel, and they decided to remove bicuspids on the case, and then after they took the bicuspids out, they placed some anchorage. She had some anchors put in at the first molar. They're kind of shallowly placed, but the screws were tight, so we were able to utilize them. So the only thing that I did on this case differently was, if I was going to camouflage the case, and he's a full class 3 obviously, I decided to mop the lower anterior teeth because I just didn't want to do any damage to these roots. So here's his initial stuff that I was able to attain from Israel, which is where he transferred from. This is how he was when we met him. So you can see the TADs are right here, mesial to the first molars. We have a pretty healthy extraction site here, and we have a full 100% underbite. There's no question there are spaces to close. So at 6 months, we were pulling him shut. At 9 months, we did our second round of mopping, and our first one was done around 5 months. And in 9 months, that's the change that we see in his facial appearance, which is significant, which goes to show you that it is incredibly effective in not just moving teeth, but also for making facial changes. Now, the last case that I'll show you before I take some questions will be a pretty hard, full-on, adult crowded case. It has a little bit of everything. It's got ectopic teeth, it's got crowding, it's got an open bite, it's got a cross bite. You know, so I look at a case like this, and I just, you know, it's just an automatic out of my mouth now. Like, if you want to get resolved and you want to feel good about yourself, we do custom-made appliances. We automatically apply acceleration to this case. So this case is going to get drilled. This case is going to get an accelerant. This case is going to get custom-made braces. In this case, on the upper, I got incognito, which is a lingual bracket. And you'll see this is a real open bite. There's no question that you know, teeth are significantly apart. There is an awful lot of crowding here, and I want a really good result. So this was the case as it started out, and at this point we were just starting to level and align stuff. We put all our appliances on, and we were getting ready to mop up the area. So we had our bicuspid extractions done. We put our braces on. This is a 4x extraction case, by the way. So pictures on the left are the initial malocclusion. Pictures on the right were the beginning of month number 2, and we mopped for the first time which was the day the teeth were pulled. She was still numb, so she came on down. I had the guy upstairs do it for me. She came on down, and we just kind of gently drilled the extraction sites. Yep, we drilled the extraction sites because we want those areas really pliable. And we drilled all around the canines, as well as the lateral incisors. So month 4 and month 5, you can see this is month 4 on the top, month 5 on the bottom, and you can really see, I hope, how much change that we have in the position of the anterior teeth. You can really appreciate I went from a big gap to a small gap in less than 4 weeks, and that was real, and it's all documented. So in this case, the canines aren't even bonded yet. You can see that I put a steel ligature tie around these teeth and I pulled them towards the arch wire, and I just pulled the teeth down. And you can appreciate how much leveling and aligning we got. So that's it. You can tell that my arch form is now being created. This is a custom-made wire, so the teeth are following the wire. I'm making enough headway on these canines I could scan them to custom build my brackets because we're a custom practice. So as you can see, sorry about that. So as you can see, I'm just leveling out the case really well. And this is a nice, progress for 8 months into a case. By month 11, both my canine brackets are on. I have full control on my case. If you don't believe that lingual brackets can upright teeth nicely, here's your examples that just absolutely show you how much control I have, and I'm not even halfway through the case yet. Most of my extraction sites are almost fully closed. My midlines are almost all the way on already. Here I am at month 20. I'm just starting to settle down my occlusion, and we're just wrapping this case up now. The open bite's closed, and cross bite is completely gone. This is a molar cross bite. It's just gone. So this is just really well-controlled mechanics in my mind. And if you look at how she started, it's really just a plethora of issues to where she is today. We got her through her wedding. She got married around month 11. She looked great for her wedding photos. Was really thankful for that. You can only hope the patients are this good. So it's really good. So why should you learn to accelerate in general using MOPS? I think just in general, what I would tell you is it's changed my practice. It's changed my ability to be able to open and close cases faster. I'm in more control. I got better axial control of teeth. Really, it's cost effective. It really makes a patient's experience better. So we're not superheroes, but we do have an awful lot of capacity now that we never had in the past. So before I answer any questions, I want to open up a quick panel and ask you. You get the vote. So the poll is now open. I want everyone to try and vote on screen really quickly. And then I'm going to give you about a minute or two to vote, and then we're going to close the poll, and we're going to see how many people do different types of acceleration. And I gave you a couple different choices here. Propel is the MOPS. Orthodontics is periodontal surgery. Piezo cuts is through the tissue. Vibration is either through the Propel unit or through the Accelerant unit. And then appliance design is like custom designed appliances like what I just showed you. So there's still 60% of you who have not voted. So, if you don't use anything, that's okay. I'm going to assume that no answer is you don't do any acceleration at all. And I don't see the numbers really. Oh, a couple stragglers here. Okay, it looks like everyone's starting to vote. I like it. Okay, 60% of you have now voted. Thank you. We're up to 61%. So it's kind of funny that I feel like Chicago, vote early and vote often. All right, so here we are. I'm gonna close the poll here, and what I'll tell you is the results are really astounding. 1 out of 2 of you use the mops, and you know what? I think it's brilliant. I'm telling you as a friend, it's changed what we're able to achieve, and it's very reasonably priced. And guess what? It just works. So it's good stuff. 28% of you said that you do appliance design. I would fall into that. I also fall into the vibration and the orthodontics. So it's kind of a tough thing. So I'm going to turn now to some questions just to see what we got. I only got 1 question. Okay, let me see if I can answer this from Yale Friedman. Oh, yours is more of a comment, just saying like that. Apparently, you do all the above, and yeah, you know what? I think it's just a matter of what everyone is used to using. You know, for me personally, I think I showed you a nice collection of cases, and you know, it's hard to argue with how all this works. Everyone has like their own ways uh, of handling this. Hold on, I'm just changing my. Oh, so this is a good question. The question is would I use Propel or a vPro 5 during the Carrier stage? I think the answer is yes, I would. Absolutely. I don't think I would Propel. I would probably I would start with, if a vPro is what you're using, I would use your vPro during that stage to loosen things up. The problem there is that the way Carrier works is it rotates the molar to get some of your molar correction. So you don't want to go too far with the tooth movement. You want, you know, so you can mop the molar specifically, but and maybe be in and out of the Carrier motion quicker. But you know, for me at the time, you know, that case is a 2-year-old case already. So I think 4 months of rubber bands with the Carrier is very acceptable. Okay, hang on, I got one other question here. Do you have many patient complaints with discomfort on the first day after we do it? If so, how do we handle it? So again, I want to repeat what we do in our office. When we mop you, we don't kick you out of the chair so fast. We swab you with chlorhexidine. We put some cotton rolls in there. You are pretty numb, so you are numb due to anesthetic. And as a result of that, we will oftentimes try to like leave you sit on your back for a while. And what I found is oftentimes the bleeding completely stops and congeals before we even pull the cotton roll out. And I don't know why, but I think the chlorhexidine has something to do with that. So I do chlorhexidine both before and after we mop, and it's really worked out pretty well for me. So I don't get a lot of discomfort, but I tell people right off the bat, if you're going to have some problems, let me know, and I will be more than happy to write a prescription for you. I'm just looking to see, let's see. Sorry, I got a little tiny window to read these questions. Was she on full-time up and down elastics? Yeah, that case was on full-time up and down elastics. Do you have many patient complaints? No. Okay. Time for one more poll. Okay. And this poll is going to be, how do you charge if you accelerate? So I'm going to give you an opportunity to vote for one last poll. If you accelerate, you have 3 options. One is, I don't, it's a part of my fee. So you just do it, and they don't see that they're paying for it. So the second is, we create a separate charge and we collect on the day we do it. And the last is, we charge separately and we build it into the case fee. So they're paying monthly, or maybe they pay a little bit up front, but they pay as they go. So again, 3 different ways you can charge out the case. We'll let this poll go for about a minute or so, just to see how you guys vote on it. Come on, vote. I need you to vote. Only 38% of you have voted. That's right. Yeah, this software is some pretty good software. I know what's going on. By and large, Let's see, we're almost to 50% of you. Okay, come on. Come on, cast your vote. Cast your vote. I'm waiting for you. Okay, I need one more person to vote so we can say we have a 50% margin here. At least, here we go. Thank you very much. Okay, so we got 56% of the people have now voted, and I'm going to close the poll. And our results show that 73% of the people who voted in our poll build the fee into the case fee, which means that you actually can say it's worth $300, $400. If I can give you a piece of advice, don't go above $500. It's worth it to lose money. Your case goes faster. Where you make real money is on the back end because your case is done sooner. Okay? So it looks like I've answered everybody's questions. And as I told you before, I got a ball game to go to because my cubbies have to play. And I need to be there. I have one last question. Specific formulation of the I'm curious as to your specific formulation. What is the approximate price of the handpiece? I don't know. You know, it's like we buy stuff. I own 4 offices, so everybody's price is different. I'll say this: the more tips you buy, the cheaper stuff gets. And I buy in bulk. Like I buy typically, 3 dozen tips at a time. Typically, and it's a big order. It's thousands of dollars, and we use it every day. So it's just part of what we do. I would tell you to talk to your sales rep in your area, and they will be more than happy to answer your questions and help you out. So for those of you who attended, I really appreciate the fact that you stuck it out. There's about 40 or 50 of you still on the line here, which is it's good. It means I kept your attention. And I hope maybe you felt that the hour of time you spent with me is worth your time. So they'll have a recording of this. I really appreciate everybody's hanging out for me, and have a good night, okay? And if there's any questions, you can always email me at my email is right here at the bottom of the screen at drneil@getitstraight.com, or you can look up my website at www.getitstraight.com. Thanks so much. I hope you have a great day, and let's get some runs. Take care. Thanks. Bye.